Welcome to Deep Dive Ortho. It's really quite remarkable how central digital devices have become in our professional lives, hasn't it?
Absolutely.
I mean, from checking patient notes on a tablet to all the admin on computers, they're everywhere. But have you ever really properly stopped to think about the silent impact, the cumulative effect all this digital engagement has on our musculoskeletal system?
It's a very important question.
Exactly. Not just on us, but crucially on our patients, too. Today, we're taking a proper deep dive into this growing orthopedic challenge. We're talking about the rise in upper extremity and neck pain that seems directly linked to, well, smartphone and computer
It's
overuse.
certainly becoming more prevalent.
We'll be looking closely at the specific conditions popping up, how they present clinically, and maybe, most importantly, the evidence-based ways we can prevent and manage them. And joining me to sort of unpick this complex area is Professor Mo Imam. Your expertise in orthopedics is invaluable in helping us make sense of the clinical data and turn it into, practical advice.
Happy to be here. It's a vital conversation to have.
Our aim today really is to equip you, our listeners, with a clearer understanding and hopefully a toolkit of pragmatic strategies. Strategies to advise your patients effectively, but also, let's be honest, to protect our own health in this, well, tech-heavy world. Professor, it's great to have you. This feels like a topic that's just getting more and more central to clinical practice, doesn't it?
It absolutely is. I mean, the sheer amount of digital interaction in modern life, it's fundamentally changed the mechanical stresses our bodies endure day to day. It's not just about those acute injuries anymore. We're definitely seeing a growing number of chronic overuse conditions, and many seem directly tied to this constant device use. It really is changing the orthopedic landscape.
That's a really powerful way to put it. And it's fascinating how our everyday language is sort of catching up, isn't it? Even if the terms aren't, official diagnoses, we hear things like text claw, text neck, gamer's thumb, even smartphone pinky. Now, they aren't formal ICD codes, but clinicians are definitely seeing more of these tech-related problems, aren't they? What do these informal terms actually mean clinically?
You're spot on. While text claw or gamer's thumb might sound a bit colloquial, they do capture genuine clinical syndromes we encounter pretty much daily now. Text claw, for instance, that usually presents as an aching or cramping pain in the fingers. It's a pretty clear sign of muscle fatigue, maybe even microtrauma, from gripping a device for long stretches. It's basically a physiological response. You've got this unaccustomed, continuous muscle contraction, repetitive movement. It's not just minor discomfort either. It can really
Yeah.
progress to affect function quite significantly.
Right, and text neck.
And text neck, yes. That's a direct result, biomechanically speaking, of keeping your neck bent forward for long periods. Sustained cervical flexion. When we hold our phones down low, say at waist or chest level, the head naturally bends forward. And that dramatically increases the load, the stress on the structures at the back of the neck. Just to give you an idea,
Yeah.
the human head weighs about, 4.5 to 5.5 kilos in a neutral position?
Roughly, yes.
Well, the effective weight on the cervical spine shoots up as you flex forward. Just 15 degrees of flexion can almost double that effective weight. And if you go to 60 degrees, which isn't uncommon when looking down at a phone,
60 degrees. Wow.
it can feel like carrying over 27 kilograms on your neck. Imagine that.
That's staggering.
This sustained, unnatural posture puts immense stress on ligaments, discs, muscles, everything in the neck and upper back.
Yeah.
It could even potentially speed up degenerative changes we usually associate with, much older people.
That idea of increased biomechanical stress it's crucial, isn't it? It really highlights what you might call the anatomical mismatch. Our hands, our bodies, they just weren't built for the constant repetitive actions involved in using smartphones and computers. All that tapping, swiping, it leads to this microtrump. Can you elaborate on the VIRIC, the pathophysiology, what's actually happening at the tissue level?
Precisely. The human hand, it's an evolutionary marvel, isn't it? Designed for incredibly diverse tasks, powerful grips, fine motor control, all sorts of movements. But it absolutely did not evolve for the sustained, highly repetitive, often low force, and frequently awkward postures demanded by modern digital devices. Think about it. Continuous tapping, typing, swiping, clutching a phone for hours. These actions don't necessarily cause a single big injury. Instead, they cause repetitive microtrauma. Tiny cumulative bits of damage at the cellular and tissue level within the muscles and tendons. This repeated mechanical stress can overwhelm the body's normal repair processes. And this unnatural sustained pressure, it leads to a chronic inflammatory response. As orthopedic surgeons like Dr. Henry Back have noted in practice, this can develop into what we call tendinopathy. often in the thumb or the finger flexors. It's a classic overuse situation. The rate of tiny injuries outpaces the body's ability to repair, leading to pain, inflammation, sometimes even thickening of the tissues involved.
So it's this slow creeping process rather than one specific event, a buildup of stress over time, which sounds very much like the broader concept of repetitive strain injury, or RSI. Is that a fair comparison? Or are there distinctions we need to bear in mind when we talk about digital strain versus other RSIs?
That's a really good question. RSI is, well, it's an umbrella term, isn't it? It covers a whole range of conditions where pain and dysfunction arise from repeated movement of a body part. It's a spectrum, often affecting the shoulders, elbows, forearms, wrists, hands, you name it. The underlying issue, the pathophysiology, involves this cumulative microdamage. Muscles, tendons, even nerves can be affected by repeating forceful or awkward movements over time. This is particularly relevant for keyboard and mouse use. That combination of static posture and a repetitive fine motor movement is almost a perfect storm for developing RSI.
And the symptoms start gradually.
Typically, yes. It often begins quite insidiously, maybe a mild twinge, a bit of discomfort, but it can progress to more serious persistent pain. Patients might describe burning, aching, throbbing pain. Often there's stiffness, maybe measurable weakness. Paresthesia is common too, that's tingling, pins and needles, numbness, sometimes muscle cramps, or even visible swelling is definitely continuing. And catching it early, intervening early, is really key to preventing chronic problems. Now, the precise causal link between, say, chronic mobile phone use and all these specific injuries, well, that's still an evolving field of research, you could say.
Right.
But anecdotally, it's compelling. Clinicians consistently hear patients report their symptoms getting worse with increased tech use. This strong clinical correlation, even if we don't have large-scale prospective studies for every single variation yet, strongly suggests a link we really can't ignore in practice.
That makes complete sense. And the sheer amount of time we spend doing these things must play a role. I remember seeing a statistic somewhere. The average American spends something like 23 hours a week just texting. That's just, it's a huge amount of time applying these micro stresses.
It is staggering, isn't it?
Are there other data points or clinical observations that really drive home how prevalent this digital strain is becoming in our patient populations?
Indeed, the scale of exposure is immense, and it's truly a global thing now. Think about findings from observational studies. For instance, one study reported that, quite strikingly, 74% of mobile device users seen in an airport were using their device with just one hand.
74%, just one hand.
Yes, and perhaps unsurprisingly, these single-handed users frequently complain of discomfort across their upper limbs, upper back, neck, which makes sense when you consider that single-handed phone use puts a much higher load on certain muscles compared to using two hands. Research using EMG, electromyography, has demonstrated this quite clearly.
Ah, okay, so there's objective data on muscle activity.
Exactly. And long-term smartphone use, well, it induces continuous mechanical stress on tendons, muscles, the surrounding tissues. This chronic stress can lead to musculoskeletal symptoms that are remarkably similar to those seen in visual display terminal syndrome, VDT syndrome. That's a well-known occupational health issue for people working long hours at computers. So what we're essentially seeing is a sort of civilianization of occupational overuse syndromes. It's moved out of the office and into every home, every pocket, transforming what was once primarily a workplace hazard into a really widespread public health challenge.
That phrase, civilianization of occupational overuse syndromes, that really resonates. It captures it perfectly. Professor, let's dig a bit deeper into some specific conditions now, maybe starting with the hands and fingers. De Quervain's tenosynovitis is quite common, isn't it? Often called mommy's thumb or texting thumb. Could you describe that for us? What should clinicians be looking for?
Certainly. De Quervain's, yes, or mommy's thumb, that nickname comes from its prevalence in new mothers, often due to repeatedly lifting infants. But it's a textbook example of an overuse injury directly linked to the kind of repetitive thumb movements we see with smartphones. Anatomically, it's about inflammation, specifically affecting two tendons at the base of the thumb, the abductor pollicis longus, APL, and the extensor pollicis brevis, EPB. These tendons run through a tight fibrous tunnel, a sheath, on the thumb side of the wrist. It's called the first dorsal compartment.
Okay.
The mechanism is basically friction and irritation. The synovium, that slippery tissue layer covering the tendons, gets inflamed and thickens because of repetitive strain. Think constant swiping, scrolling, rapid thumb typing. This thickening narrows the space in that tunnel, causing friction when the tendons try to glide. And that friction leads to pain whenever the thumb and wrist move, especially with gripping or bending the wrist towards the little finger side, ulnar deviation.
And diagnosis. Is there a specific test?
Yes. The classic clinical test is Finkelstein's test. You ask the patient to tuck their thumb into their palm, wrap their fingers around it to make a fist, and then gently bend the wrist downwards towards the little finger.
Okay.
If that movement reproduces sharp pain on the outside of the wrist, over the radial styloid bone, that's a strong indicator for Dick veins. Symptoms typically include an aching or throbbing pain, thumb, palm, wrist, sometimes radiating up the forearm. Patients might also mention intermittent tingling or numbness in the fingertips, especially the thumb and index finger, and they often feel stiffness or cramping in their hands, particularly first thing in the morning or after using their phone for a while. You might also find demonstrable weakness in their grip or pinch strength.
That's very clear, thank you. Another one affecting the fingers is trigger finger. How does that typically present, and what's the underlying pathology causing that distinctive catching or clicking?
Trigger finger, or stenosing tenosynovitis, as it's formally known, presents with a digit, often the ring finger or the thumb, though it can be any finger that consistently locks or catches when bending or straightening. Patients often describe an audible click, or maybe a pop, when it happens, which can be quite alarming for them.
I can imagine.
The mechanism involves the pulleys. These are fibrous tunnels that hold the finger flexor tendons close to the bones. With repetitive gripping, or maybe forceful movements like holding a phone too tightly for too long, these pulleys can become inflamed and thickened, particularly the A1 pulley right at the base of the finger in the palm. This inflammation makes it difficult for the flexor tendon to glide smoothly through the pulley. Over time, the tendon itself might develop a small lump, a nodule. It's this nodule trying to squeeze through the narrowed, inflamed pulley that gets caught. That causes the characteristic locking and often a painful release or snap when it finally goes through. Patients often say they have trouble straightening the finger once it's bent, sometimes needing to use their other hand to pull it straight.
Right, that makes sense.
And what about the slightly odd smartphone pinky? Is that just a cosmetic thing, or does it signal something more significant clinically?
Smartphone pinky. Yes, it's a direct result of sustained pressure, usually from resting the bottom edge of the phone on the little finger repeatedly. It often looks like a visible indentation, maybe a callus, on the side of the pinky finger. Now, usually it's not painful in itself,
Okay.
but it's a really useful clinical sign. It tells you about suboptimal holding habits. It highlights a prolonged, static point of contact, often under some load. It suggests the overall hand posture during phone use might be contributing to other, more symptomatic problems elsewhere in the hand or wrist. So for a clinician, it's like a little red flag, a visual cue to ask more questions. How do you hold your phone? Are you getting any other pain or discomfort in your hand, wrist, or arm? It points towards a sustained ergonomic fault that's likely putting other structures under strain, too. That's a great point, a simple visual clue telling us to investigate further. Good tip. And speaking of clues, if we follow these issues up the arm, what are we seeing at the elbow and forearm? Cubital tunnel syndrome, sometimes called cell phone elbow, seems increasingly common. Can you explain the anatomy there and how device use plays a role?
Certainly. Cubital tunnel syndrome happens when the ulnar nerve, that's the nerve that gives you the funny bone sensation, gets compressed or stretched where it passes through the cubital tunnel on the inner side of the elbow. This nerve supplies sensation to the little finger and the ring finger, and it also controls some of the small intrinsic muscles in the hand that are vital for fine motor skills like grip and pinch.
Right.
The classic symptoms are numbness or tingling, that pins and needles feeling specifically in the ring and little fingers. Sometimes this is accompanied by pain and often weakness in the hand, making tasks like buttoning a shirt or opening a jar difficult. The direct cause is usually sustained compression or stretching of that ulnar nerve when the elbow is bent sharply for long periods.
Like holding a phone to your ear.
Exactly. Holding a phone to the ear for long calls is a prime example. But even resting your elbow on a hard desk while using a computer for hours can do it. That flexed position narrows the cubital tunnel and can put tension on the nerve, potentially leading to nerve irritation or even reduced blood flow.
And how do you confirm the diagnosis?
Well, the clinical picture is often very suggestive. Patients frequently report their symptoms get worse with prolonged elbow bending. But electrical conduction tests, nerve conduction velocity studies, can objectively confirm that nerve signals are slowed down across that elbow segment. This helps confirm the diagnosis and can guide decisions about management. It's interesting, actually. There's a historical parallel with BlackBerry thumb or even radial tunnel syndrome that some traders and bankers got from using those early BlackBerry devices so intensively.
Ah, yes, I remember that.
It really shows how shifts in technology repeatedly create new patterns of repetitive stress injuries. It means we constantly have to adapt how we diagnose and treat these things.
It's fascinating how the specific tech shapes the injury. Now, moving beyond nerve entrapment, what about more general forearm pain from typing? What are the usual suspects there and how do they present?
Forearm discomfort, forearm pain. Yes, very common complaints, especially for people who type a lot. The causes are often, well, multifactorial. Firstly, poor ergonomic setup is a huge factor. Think awkward sitting posture, slouching, leaning forward, or straining to reach the keyboard or mouse, or gripping the mouse really tightly. These postures force sustained, often unnatural contractions in the forearm muscles, both the extensors on top and the flexors underneath. That leads to fatigue and strain.
Makes sense.
Secondly, and perhaps more fundamentally, it often comes down to repetitive strain injury, RSI again. The constant small, rapid movements of typing, especially without enough breaks, can cause that cumulative microdamage in the forearm muscles and tendons. This can show up as burning, aching, or throbbing pain, maybe stiffness, even weakness. It can make everyday tasks quite painful. Mouse arm, for example, is a specific type of RSI pain in the shoulder, forearm, hand, or wrist, directly linked to overusing the mouse. It really highlights the need for good mouse ergonomics and technique.
Are conditions like tennis elbow or golfer's elbow related to typing too?
That's a good point to clarify. Lateral and medial epicondylitis, tennis elbow, and golfer's elbow are definitely RSIs that cause forearm pain, often near the elbow. But their main cause usually involves specific activities with forceful wrist extension or flexion, often combined with forearm rotation. They aren't typically caused primarily by typing, although typing can certainly make them feel worse if you already have them.
Right, different mechanism.
Exactly.
And it's also crucial, clinically, to remember that forearm pain isn't always musculoskeletal. It could stem from arthritis in the elbow or wrist. Or, rarely but importantly, could even be referred pain, maybe from a cardiac issue like angina. So a thorough clinical evaluation is always needed to rule out other causes and get the diagnosis right. We always need to consider the bigger picture.
That's a really important diagnostic reminder. Thank you. Moving up again, let's revisit text neck. We talked about the increased mechanical load. Are there specific muscle activity patterns or compensatory things happening that support this?
Absolutely. Going back to text neck, the fundamental problem is that sustained forward head posture, that cervical flexion. As we discussed, it massively increases the tension in the muscles at the back of the neck and the upper back. The head is heavy, and the further forward it goes, the greater the lever arm and the harder those posterior muscles have to work to hold it up. This sustained tension leads to muscle fatigue, potentially shortening of muscles over time, and ultimately pain in the neck, shoulders, sometimes even radiating symptoms or headaches.
And there's research backing this up.
Yes, indeed. There's empirical evidence. One study specifically looked at muscle activity using EMG during smartphone use. It found significantly higher activity in the upper trapezius muscle, the UT, and also in key thumb muscles like the extensor pollicis longus, EPL, and abductor pollicis, AP, during single-handed phone use compared to using two hands.
So single-handed use is demonstrably worse.
It seems so, yes. The implication is quite significant. Using one hand doesn't just correlate with people reporting more upper trap pain, it objectively causes increased muscle activity in the upper limb. The upper trapezius, for example, it acts as both a mover and a key stabilizer for the shoulder girdle and arm. So that increased activity in the thumb muscles and the upper trap might actually be the body compensating for the instability inherent in trying to both hold and manipulate the phone with just one hand.
Right, the muscles working overtime to stabilize everything.
Exactly. And that increased muscular effort contributes directly to the pain and fatigue people feel. It can even be a factor in cervicogenic headaches. It clearly shows how our bodies try to adapt, but often that adaptation comes at a cost.
That's a critical piece of the puzzle, understanding those biomechanics and compensations. Beyond these more localized issues, are there any broader, perhaps systemic conditions that get worse with or are even caused by excessive digital device use? You mentioned distraction injuries earlier, too.
Yes, there are definitely broader impacts to consider. Carpal tunnel syndrome, CTS, is a major one. Now, it's not exclusively caused by digital overuse, but it's incredibly common, causing pain, numbness, tingling in the hand and arm, and its link with excessive texting and typing is pretty well established now.
How does typing contribute to CTS?
Well, CTS happens when the median nerve gets compressed as it passes through the carpal tunnel, that narrow channel in the wrist. This nerve gives sensation to the thumb, index, middle, and half the ring finger and controls some thumb muscles. The repetitive bending and straightening of the wrist, which is inherent in a lot of prolonged typing and texting, especially with poor posture, can lead to inflammation and swelling of the tendons that also run through that tunnel. That swelling then squeezes the median nerve.
And treatment depends on severity.
Precisely. Early stages might respond well to non-operative things, maybe a forced break from the phone or keyboard, night splinting to keep the wrist straight, activity modification.
Mm.
But if symptoms are severe, persistent, or if there's muscle wasting or signs of irreversible nerve damage, then surgery to release the pressure on the nerve might be necessary.
Okay. And the distraction injuries.
Ah yes, the distraction injuries. While they aren't orthopedic conditions per se, we absolutely have to acknowledge them. The pervasive use of smartphones, especially while walking, has led to a noticeable rise in people getting injured simply because they aren't paying attention. We see patients who've walked into lampposts, tripped over curbs, fallen down stairs, all because their attention was captured by their device. It's a serious public health and safety issue stemming directly from smartphone use. And as medical professionals, we should probably be mindful of it, maybe even counsel patients about it, especially if they present with related injuries. It's an often overlooked consequence of being so digitally immersed.
Absolutely. A very important point. Okay, that gives us a really thorough understanding of the problems. Let's switch gears now and focus on being proactive. For our listeners, both for advising patients and for themselves, what are the key behavioral changes we should be promoting, particularly around smartphone use?
Prevention is absolutely key, and it really starts with being more mindful, adjusting our behavior. The golden rule, the one we all know but often ignore, is simply take regular breaks from your device. It's like the 20-20-20 rule for eyes, isn't it? Every 20 or 30 minutes, just put the phone down, look away from the screen. Ideally, get up and move a bit. This lets muscles and tendons relax and significantly cuts down the risk of repetitive strain.
It sounds simple, but hard to stick to sometimes.
It is. That's why setting timers can be really helpful. On your phone, on your watch, just a gentle nudge to disengage. It's all about breaking up those static postures and the cumulative load. Secondly, encourage people to alternate hands when using their phone. Such a simple thing, but it helps spread the load across both arms and hands, preventing one side from getting overloaded. Many of us have a dominant phone hand without even realizing it. Consciously switching can make a real difference.
Good point.
Thirdly, make use of hands-free features whenever practical. For long calls, definitely advise using headphones or a headset that totally avoids holding the phone to the ear, reducing that sustained elbow bending which can lead to cubital tunnel syndrome. And also, really encourage using voice commands, sending audio messages, using speech to text. Anything that cuts down on manual typing and swiping gives the fingers, hands, and wrists a much-needed break.
Yeah, those features are getting much better now, too.
They are. And finally, perhaps the broadest advice is to counsel on limiting overall screen time. The benefits go way beyond just orthopedics, psychological well-being, sleep, eye strain. Most phones now have built-in screen time trackers. These can be fantastic tools. You can help patients monitor their usage, set realistic goals for cutting down, and see their progress. It's really about fostering a more balanced, conscious relationship with technology, using devices as tools rather than letting them dictate our posture and habits all day long.
Those behavioral shifts are fundamental, aren't they? Addressing the how often and how much. Let's move on to ergonomic adjustments now for the devices themselves and for workstations. Starting with phones, how should we ideally be holding them? What are the best practices?
Yes, how we physically hold the phone matters a lot. Seemingly small tweaks can significantly reduce strain. Firstly, whenever you can, advocate using both hands to hold the device. It distributes the weight, provides more stability, and dramatically reduces the strain on individual fingers and wrists. It also tends to promote a more neutral posture overall. Secondly, consider recommending ergonomic accessories, things like a stylus for scrolling or typing, or even just a simple pop socket or ring grip on the back. These can help maintain a straighter, more neutral wrist position, which is key for preventing things like Dick Ravanes by reducing those repetitive thumb movements and forceful gripping. Thirdly, and this is vital for the neck, advise people to hold the phone at eye level. This one change makes a huge difference in reducing how much you bend your neck forward, minimizing that neck and shoulder tension and the risk of text neck. As some clinicians suggest, you can find ways to do this even when standing or lying down, maybe resting elbows on your chest or using pillows to prop the device up to eye level when sitting or lying. The principle is always the same. Align your head, neck, and the device to avoid that forward head posture.
Right, bring the phone up to you, not your head down to the phone.
Precisely. And finally, when holding the phone, encourage keeping the elbow relatively straight, or at least not acutely bent for long periods. As we discussed, prolonged sharp elbow bending can affect blood flow and compress the ulnar nerve. If someone finds they have to bend their elbow sharply because they can't see the screen properly, that flags up another issue. They should probably get their vision checked and ensure they have the right prescription glasses so they don't need to bring the phone unnaturally close. Addressing vision problems can indirectly prevent arm problems.
That's a really comprehensive set of tips for phone use. Let's switch to computer workstations now. So many of us spend hours at a desk. Where do we start with optimizing posture for using a desktop or laptop?
Right, the workstation. It's a whole system, really, and posture is the foundation. Firstly, it's crucial to maintain a neutral head position, keeping your chin roughly parallel to the floor. This stops you craning your neck forward or tilting your head back too much, both of which strain the neck. Secondly, adjust your chair height. You want your feet flat on the floor or on a footrest if needed. Your knees should be bent at roughly 90 degrees, maybe slightly more open, with your thighs sloping gently downwards. This helps align your lower body and takes pressure off your lower back and hips. And thirdly, make sure you have good lumbar support. Your chair should support the natural inward curve of your lower back, that lumbar lordosis. This prevents slouching, which flattens the lower spine and puts strain on the discs.
Okay, chair sorted. What about the monitor? How important is its placement for our neck health?
Monitor placement is absolutely key. For eye comfort, yes, but especially for your neck. Position the monitor directly in front of you, not off to one side where you have to constantly turn your head. It should be roughly an arm's length away, typically somewhere between 45 and 75 centimeters, depending on screen size and your vision. And critically, the top of the screen should be at, or perhaps just slightly below, eye level. This setup naturally encourages a straight alignment of your head and neck. It stops you looking down, which, as we know, contributes massively to neck strain, even at a desk.
And if you use multiple monitors?
Good question. If you have multiple monitors, try to arrange them in a slight arc directly in front of you, or if you use one more than the others, put that primary monitor right in the center, with the secondary one slightly off to the side, angled inwards. Minimize head turning as much as possible.
Right, makes sense. So, chair, monitor. Now the keyboard and mouse, these are our direct interaction points and often where RSI issues creep in. What's the ideal setup here?
For the keyboard and mouse, the main goal is to avoid those unnatural wrist and arm postures that can lead to problems like tendinitis or carpal tunnel. Position the keyboard so your forearms are roughly parallel to the floor, and crucially, your wrists remain neutral straight. Avoid bending your wrists up into extension or down into flexion or sideways towards the little finger or thumb. Your elbow should be relaxed, bent at about 90 degrees, and your upper arms should hang comfortably close to your body, not sticking out to the sides. Keep the mouse close to the keyboard, within easy reach. This minimizes reaching out with your shoulder. When you grip the mouse, try to do it lightly. Avoid that tight, forceful grip which really fatigues the forearm muscles. And a really basic but often overlooked point, use all your fingers when typing, not just pecking with one or two or relying heavily on your thumbs if it's a laptop trackpad. Distributing the work across more fingers reduces the load on any single tendon or muscle group.
That leads nicely onto ergonomic keyboards. They come in all shapes and sizes, and it can be a bit confusing navigating the options. Can you walk us through the main types, their benefits, and what features people should look out for?
Yes, ergonomic keyboards can be a significant help, specifically designed to reduce strain by promoting more natural hand and wrist postures. They generally fall into two main camps: single-piece, often curved designs, and split chassis designs. Single-piece or unibody keyboards usually have a fixed curve built in. Their main aim is to reduce that twisting of the forearms, wrist pronation supination. Some models are curved and might have a subtle split, often with a built-in wrist rest and maybe negative tilt capability where the front edge is higher than the back.
Are they easier to get used to?
Generally, yes. They often have a shorter learning curve because the layout feels a bit more familiar than a fully split keyboard. But because they're one unit, they can't fully accommodate individual differences in shoulder width. Can't separate the halves to match your body. Then you have the split chassis keyboards. These offer the most customization. They literally split into two separate halves. This lets you position each half independently, setting the width and the angle to perfectly match your own body shape and size.
So you can get a truly neutral position.
Exactly. You can position your hands directly in front of your shoulders, which is ideal for wrist, forearm, and shoulder alignment. Some are quite advanced with extra features like USB ports, or they might be mechanical keyboards where you can even swap out the key switches. Two key features to understand are tenting and reverse tilt. Tenting means the keyboard slopes up towards the middle like a tent shape. This reduces how much your wrists have to twist inwards, pronate, to lie flat. It keeps them in a more neutral, handshake-like position. Reverse tilt means the edge of the keyboard closest to you is tilted upwards, so the keyboard slopes slightly away from you. This helps prevent your wrist from bending upwards into excessive extension. Some keyboards have these features built in, others might need optional lift kits.
Interesting. And you mentioned key switches. Does the feel of the keys matter?
It can, yes, especially if someone is already experiencing pain. Key switches determine how much force you need to press a key and the tactile feedback you get. Lighter switches, like Cherry MX Red types, require less force per keystroke. This can be beneficial compared to heavier switches, like Cherry MX Browns, as it reduces the cumulative strain on the fingers and tendons over a long typing session.
But there's a learning curve with these ergonomic keyboards.
Oh, definitely. You have to acknowledge the learning curve. Adapting, especially to a split keyboard, takes time and patience. Maybe 1 or 2 weeks for a unibody, perhaps 2 to 4 weeks, to feel really comfortable and fast on a split design. But consistency is key. It does get easier with practice, and the potential long-term benefits for your wrists and arms are often well worth the initial adjustment period. A good tip for split keyboards is to start with the halves close together, almost like a normal keyboard, and gradually move them apart as you get used to it. Same with tenting or tilt start low and gradually increase the angle.
That's a really helpful breakdown of ergonomic keyboards. Are there similar options for mice? And what about just organizing the workstation itself beyond the main components?
Absolutely. Just like keyboards, ergonomic mice aim to minimize stress. Vertical mice are a great example. They keep your wrist in that neutral handshake position, reducing forearm twisting or pronation. Trackballs are another option. Your hand stays relatively still, and you move the cursor with your thumb or fingers. This minimizes large arm movements from the shoulder and elbow. Both can be much better than traditional flat mice for maintaining a neutral posture. As for the overall workstation layout, think efficiency and minimizing unnecessary movement. Using a document holder placed right next to your monitor, ideally at the same height, is a simple but effective change. It stops you constantly looking down and twisting your neck when referring to papers. Also, try to avoid clutter on the desk. Keep frequently used items, phone, notepad, pen within easy reach, inside that immediate reach envelope. Store less frequently used things further away or off the desk entirely. It's about creating a workspace that's streamlined, efficient, and fundamentally kind to your body, reducing those little strains that add up over the day.
So, beyond the hardware and the immediate setup, what about those broader healthy habits? Things people can integrate into daily life to support their musculoskeletal health in this digital age. These are often the trickiest ones for patients to actually adopt, aren't they?
You're absolutely right. Behavior change is often the hardest part, but it's so vital for overall musculoskeletal health. Firstly, regular stretching. It sounds basic, but it's paramount. Simple, targeted stretches help keep the wrists, hands, and fingers flexible. They prevent stiffness, improve circulation. Things like gently bending the wrist forwards and backwards, spreading the fingers wide, making a fist. Easy things to do periodically throughout the day, even during very short breaks.
Just taking a minute or two.
Exactly. Secondly, encourage varying posture. If someone has access to a standing desk, advise them to alternate between sitting and standing, maybe every 30 minutes or so. This dynamic movement stops prolonged static loading on any one part of the spine or limbs. It promotes circulation, keeps muscles active rather than getting statically fatigued. Even without a standing desk, just getting up, walking around, doing a few light stretches every hour makes a difference.
Good point.
Thirdly, hydration. Often overlooked, but really critical for tissue health. Emphasize drinking plenty of water throughout the day. Well-hydrated tissues, including tendons and fascia, are generally more pliable, more resilient, less prone to injury, and they recover better.
Okay.
For those who do use standing workstations, mention footwear. Avoid high heels. Choose supportive cushioned shoes. And advise keeping feet shoulder-width apart, maybe shifting weight occasionally side to side or front to back. This provides a good base of support and reduces static load on the legs and back.
And leveraging technology itself.
Yes, paradoxically. Suggest using desktop programs or apps that give reminders to stretch, to take a break, to stand up. These digital nudges can be surprisingly effective, especially in busy work environments where it's easy to get absorbed and forget. It's all about building these healthy habits into a conscious routine.
Those are really valuable proactive measures. Together, they form a pretty robust preventative strategy. But what happens when pain does set in, despite these efforts? What are the initial self-management steps clinicians should recommend? And when does it become time for professional help?
Right, when pain persists, we shift focus to management. Initial self-management is key. Firstly, rest and avoid aggravation. Seems obvious, but it means immediately resting the affected part and rigorously avoiding activities that make the discomfort worse. However, it's crucial to caution against prolonged inactivity. Resting for more than a few days can actually lead to weakness and stiffness, disuse atrophy, joint contractures. The body needs time for the acute inflammation to settle, but then controlled movement is usually needed for proper recovery.
Okay, so rest, but not too much rest.
Exactly. Secondly, temperature therapy can be very useful. If there's acute inflammation, swelling, redness, then applying an ice pack, maybe 10 minutes on, 20 minutes off, several times a day can help. Cold reduces inflammation, constricts blood vessels, and numbs the area a bit. Conversely, for chronic stiffness or muscle tightness without much swelling, a hot compress or heat pack can be better. Heat helps relax tense muscles and tendons, improves local blood flow, makes tissues a bit more pliable. You can even combine them. For example, when doing nerve or tendon gliding exercises, some therapists suggest applying heat for 15 minutes beforehand to warm things up, and then ice for 20 minutes afterwards to prevent any post-exercise flare-up.
That's a useful tip.
Thirdly, simple over-the-counter pain relievers. Paracetamol or non-steroidal anti-inflammatories, antialides like ibuprofen or naproxen, either tablets or topical gels, can help manage pain and reduce inflammation. Obviously, use them as directed and be mindful of any contraindications for the patient. Fourth, targeted massage of the affected area can provide good relief. This could include self-massage, maybe using a foam roller for the forearms, or gentle manual massage. It can help relieve muscle and joint pain, improve flexibility, aid recovery by breaking up muscle spasms, releasing tight fascia, and calming irritated tendons. And finally, braces or splints can be valuable. For conditions like de Quervain's or cubital tunnel, a well-fitted brace or splint provides support, can temporarily immobilize the area to allow healing, alleviate direct pressure, and promote better alignment. They're often used during activities that aggravate symptoms or sometimes overnight.
Those are excellent first-line strategies. Very clear. If these conservative measures don't cut it, when do we start thinking about professional intervention like physiotherapy or maybe more advanced treatments for these digital age injuries?
If symptoms aren't improving with those initial self-management steps, then referral for professional help, usually physiotherapy or occupational therapy, is the logical next step, and often very effective. Therapists can do a thorough assessment, pinpoint the specific problems, muscle weakness, lack of flexibility, joint stiffness, nerve issues, and then design a tailored exercise program. They guide patients through progressive exercises to build strength, improve mobility, and address the specific biomechanical issues driving the problem.
Can you give some examples of exercises they might use?
Sure, for general arm stretches that might help with diffuse pain from phone use, they might include a tricep stretch, maybe leaning against a wall with the elbow bent overhead, holding for 30-60 seconds, a couple of sets, helps release shoulder and upper arm tension. A forearm extensor stretch, arm straight, palm down, gently pulling the fingers towards the floor, hold for 30 seconds. Stretches the top of the forearm. And a forearm flexor stretch, arm straight, palm up, gently pulling fingers down towards the floor, hold 30 seconds. Targets the underside of the forearm. Doing these regularly, maybe twice a day, helps maintain flexibility.
Okay. And for strengthening?
For strengthening, particularly if the forearm extensors are weak from typing, an eccentric extensor exercise is often key. The patient uses a lightweight, maybe just a tin of beans or a very light dumbbell, half a kilo or so. They use their other hand to lift the weight up into wrist extension, and they slowly lower the weight down, resisting gravity.
Controlling the downward movement.
It's exactly, the eccentric phase. Typically starting with maybe 2 sets of 5 reps, gradually working up to 3 sets of 10, perhaps twice a day. If doing it with the arms straight is too hard initially, they can do it with the elbow bent at their side. For specific conditions like carpal tunnel syndrome, established guidelines, like those from OrthoInfo, outline specific exercises. There are wrist extension and flexion stretches, similar to the general ones, but held for maybe 15 seconds, repeated multiple times a day. Then there are median nerve glides. These are a specific sequence of, usually 6, hand and wrist positions designed to gently move the median nerve within the carpal tunnel. The aim is to reduce adhesions and improve how the nerve slides. Each position is held for just a few seconds, maybe 10-15 reps a day. It's quite a precise sequence: fist, finger straight, wrist back, thumb back, forearm turned up, gentle stretch.
Needs careful instruction, presumably.
Oh, absolutely. Best taught by a therapist. And also tendon glides. These are sequences of finger movements making a straight hand, then a hook fist, then a full fist, or a tabletop shape designed to ensure the flexor tendons are gliding smoothly through their sheaths in the fingers and palm. Again, specific positions held briefly, repeated regularly. And it's worth mentioning, nerve glide exercises can also be very effective for things like cubital tunnel syndrome. Anecdotally, some patients report quite immediate relief when they do the correct nerve gliding exercises, again under professional guidance.
Beyond therapy and exercises, what else is in the toolkit?
Well, if things still aren't settling, medication might play a bigger role. Localized corticosteroid injections can be very effective for calming down specific spots of inflammation in a tendon sheath for de Quervain veins, near the carpal tunnel or around an irritated nerve. They provide potent, targeted anti-inflammatory effects. Oral NSAIDs might also be used more consistently for a period. And then, in severe or persistent cases where conservative treatment has really failed despite a good trial, surgery becomes an option. Procedures like carpal tunnel release to physically cut the ligament over the tunnel and give the nerve more space. Or surgery for cubital tunnel syndrome, maybe moving the nerve or just releasing the tight tunnel. Or releasing the tight tendon sheath in de Quervain veins or the tight pulley in trigger finger. These aim to fix the underlying mechanical problem.
That covers a wide range of interventions, from the simple to the surgical. Finally, and this is perhaps crucial for our listeners, when should a medical professional advise their patients, or maybe even themselves, to seek that specialist help? What are the red flags or triggers for a referral?
That's a critical question, knowing when to escalate care. We should definitely advise patients to consult a specialist, like a hand surgeon or an orthopedic specialist. If their symptoms, numbness, tingling, cramping, stiffness, continue or get worse even after they've stopped the aggravating activity and tried initial measures. Other clear signs for a referral would be severe pain that just isn't settling after, say, a few days to a week of proper conservative management, or if the symptoms are significantly impacting their daily life, affecting their work, their ability to do hobbies, basic self-care.
And neurological signs.
Absolutely. Any progressive weakness, noticeable muscle wasting, particularly in the small muscles of the hand, or persistent neurological deficits like constant numbness, those are definite red flags, requiring specialist evaluation fairly promptly. The reason for intervening early is significant. It can genuinely prevent conditions like advanced carpal tunnel, cubital tunnel, chronic tendinopathies, or even secondary arthritis from becoming irreversible or truly debilitating. The sooner you get an accurate diagnosis and start the right targeted treatment, the better the chances of a good long-term outcome. And within a work context, it's also important people know to listen to their bodies and maybe talk to their HR department or the workplace health and safety team if they're experiencing discomfort at work. These teams can often arrange ergonomic assessments or advise on adjustments. Prevention and early intervention really are our most powerful tools here.
This has been an incredibly insightful deep dive, Professor. Truly comprehensive. We've gone from that subtle anatomical mismatch right through to advanced therapies and when to refer. Just to recap then, it seems while technology is undeniably vital in our modern lives, actively protecting our orthopedic health from its effects is just crucial for all of us and for our patients.
Absolutely. I think our conversation really underscores that point. These digital devices, while they offer so much, they also bring this distinct set of musculoskeletal challenges. The key takeaway, I hope, is about being proactive. Prevention. By consciously applying ergonomic principles, how we hold our phones, how we set up our workstations, maybe investing in ergonomic kit, we can genuinely reduce the risk. And equally vital are those behavioral changes we talked about, taking regular breaks, switching hands, using hands-free options, managing screen time. Combine those with general healthy habits, stretching, moving, staying hydrated, and you have a really robust preventative strategy. And when symptoms do pop up, it's about recognizing them early, trying appropriate self-management, and knowing when to seek professional help, whether that's physio, injections, or sometimes surgery. It's really about empowering ourselves and our patients to take control of their digital health.
Indeed. Cultivating that healthier relationship with technology where innovation doesn't have to mean compromising our physical well-being. So, as we wrap up, I'd like to leave you, our listener, with a final thought to mull over. In this world where technology just keeps evolving at such breakneck speed, how do we ensure our physiology can keep pace? How do we foster innovation without sacrificing the long-term musculoskeletal health and vitality of our communities? Something to think about. Professor, thank you so much for sharing your invaluable expertise with us today. It's been fascinating.
It's been my pleasure entirely. Thank you for the excellent discussion.
And to you, our listener, if you found the depth and detail of this deep dive useful for your practice or just your own understanding, please do take a moment to rate and share Deep Dive Ortho with your colleagues. Your engagement really helps us extend the reach of these important orthopedic insights. Until next time, stay informed and stay well.